Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
This activity includes discussion of off-license or unapproved therapies. Please consult your local SMPC or its equivalent for further information.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from AstraZeneca.
Hello, I'm Erica Mayer, Director of Breast Cancer Clinical Research at the Dana-Farber Cancer Institute in Boston, Massachusetts, in the United States. Welcome to this program titled, How Are Oral SERDs Changing the Management of Advanced Hormone Receptor Positive Breast Cancer? Joining me today is François Clement Bidard, Professor of Medical Oncology at the Institut Curie in Paris, France. Welcome.
Hello.
So we're going to jump right in, and I'd love for us to begin by looking at the data for oral SERD monotherapy in the second-line setting.
Yes, the story started with the Emerald trial. So that trial has enrolled nearby 500 patients, and this trial was initiated like before 2020 with the first-in-class oral SERD elacestrant. And what the trial has been shown to, it's a phase 3 trial comparing in second line elacestrant versus standard of care endocrine therapy given as single agent, so mostly fulvestrant, but also some patients were treated with aromatase inhibitor in the standard arm. And this was the first trial to show that there was a clear superiority of oral SERD versus standard of care single agent endocrine therapy in patients with ESR1 mutation detected in blood prior to treatment initiation, so at time of disease progression after a CDK4/6 inhibitor. So this trial was really the first trial to show it, and you will see that other trials have repeatedly reported the same outcome. Numerically, the median PFS was somehow limited, with a median PFS of about 3 to 4 months in patient with ESR1 mutation being detected. So elacestrant has been approved in Europe and also in the US and is used in several countries, and we'll discuss later how to use this single agent SERD. What is interesting is the result of EMBER-3, because EMBER-3, so it's a 3-arm trials, but 2 arms of EMBER-3 were about single agent endocrine therapy. And so standard of care, so mostly fulvestrant, but also some patients treated with aromatase inhibitor, and single agent imlunestrant, which is another oral SERD, which was given as single agent in one of the 3 arms of EMBER-3. And what is very interesting is the results were somehow replicated. The median PFS was longer, but it also reflects that patients were less pretreated in EMBER-3 compared to EMERALD. And again, the benefit was observed and was restricted to a patient harboring an ESR1 mutation in their blood prior to treatment start. So that's the second agent, second oral SERD to show the superiority versus standard of care single agent. And at the moment, imlunestrant is not yet approved in Europe, but was already granted FDA approval in the US.
Yeah, so it's so exciting to have agents that are now approved for specific resistance mutations. Yet, I personally find it somewhat frustrating that as monotherapy, these agents have been unable to cross the 6-month barrier for progression-free survival. And when we look at the Kaplan-Meier curves for monotherapy, we can see that there's a number of patients who drop off, who progress at time of first restaging, suggesting there's definitely endocrine resistance in this pretreated population, something that perhaps is better addressed through the use of a combination using an endocrine therapy with a targeted partner. We've now had at least 2 trials giving us experiences looking at oral SERD combinations in the second line setting. getting back to EMBER-3, there was a third arm of EMBER-3. It was added a little bit later, looking at the combination of imlunestrant with the CDK4/6 inhibitor abemaciclib. And results of this comparison showed that those who received the combination of imlunestrant and abemaciclib in the ITT population definitely surpassed that 6-month barrier with a median progression-free survival of 9.4 months, which at the time this data was presented was the longest PFS in the second-line post-CDK setting that we had seen. And this was compared to imlunestrant monotherapy, so combination versus monotherapy. Importantly, also for this third arm of EMBER-3, the benefit of the combination was seen in both the ESR1 mutant and the ESR1 no mutation detected populations, perhaps suggesting that when you use a combination, that might overcome any restriction of the oral SERD based on presence or absence of the ESR1 mutation. Um, Most recently, we've seen data from the phase 3 Avera study. Avera is utilizing the oral SERD giredestrant. And in the Avera study, this was second-line study, all patients had had up to 2 prior lines of endocrine therapy. All patients had had prior CDK4/6 inhibitor. No patients had had prior chemotherapy. So it's always important to consider, what is the population that's under study in the trial. Patients were randomized to receive the oral SERD giredestrant with the oral mTOR inhibitor everolimus versus a standard of care endocrine therapy plus everolimus. And again, the two primary endpoints were looking at progression-free survival in the ITT population and in the ESR1 mutated population. What we saw was in the ESR1 mutant population, the progression-free survival using giredestrant and everolimus was approaching 10 months. So again, surpassing that 6-month barrier compared to the combination comparison of endocrine therapy with everolimus, which was about 5.5 months. The benefit of giredestrant was also seen in the ITT population, again, a primary endpoint, where the patients who received giredestrant had a prolongation in progression-free survival compared to those who received standard of care endocrine therapy, with a PFS of about 8.8 months. So again, breaking that 6-month barrier. Importantly, in Avera, the contribution of toxicity from giredestrant was really negligible. The toxicity in both arms of the study was quite identical and mostly reflected the use of everolimus and the common toxicities that we know about with everolimus. There was very low rates of grade 1 bradycardia, which we can see with some of the oral SERDs, but this didn't require any interventions. It did not bother patients. So overall, this was a really exciting data from both of these combination studies. And although neither of these combinations is currently approved, I think it's really exciting to see data where the PFS is crossing that 6-month barrier. So, Francois Clement, what do you think about this data? And in particular, if we're thinking about the second line setting, which patients would you be thinking about for an oral SERD, either as monotherapy or in combination?
Well, so I think that again, EMALT with the first-in-class third, like elacestrant, like showed the way that obviously PFS given as single agent are short and the efficacy is short-lived. So they were trying to figure out which patient would benefit the most and would have the longest PFS. And at the end, what we were able to report is that patients who had, let's say, a long PFS in first line were the ones that were more likely to benefit from a second line endocrine therapy and also from a second line endocrine therapy with a third given as single agent. So I think that at the moment we don't have much tool to really distinguish patients who really would really benefit from second line endocrine therapy, but we have to base our clinical judgment mostly on first line PFS to navigate between second line based on single agent or second line based on combination therapy. So that's so the way I would say it is that for a patient who had a very long response and PFS in first line, so this patient would be more likely to be treated with second line endocrine therapy. But of course, the use of oral SERD at the moment is still triggered by the presence of ESR1 mutations.
Right. And I think we're all excited to begin to have this available for our patients. I think the restriction of the monotherapy to the ESR1 mutation means that we're targeting just one pathway of resistance. But we know resistance to therapies is complicated in metastatic breast cancer, and use of a combination allows targeting of multiple pathways. Perhaps that's why we see the improved progression-free survival when we use combinations. Looking forward, my preference would be to select combinations, if and when they're available. And it is intriguing from the data that these benefits may not be just restricted to ESR1 mutant populations, but could be available for a broader selection of patients. So let's talk about moving oral SERDs even earlier on into treatment and into the first line setting. One of the most exciting studies that I think we've seen in the past few years is the Serena 6 trial.
Yes, we with pleasure. So it's a Serena 6 is a very important trial because it's a new approach, and that new approach relies on the use of ctDNA used as a tool to monitor the disease throughout the first line. So with repeated ctDNA tests, and in the trial it was done every 3 months, we are able to intercept ESR1 mutation as soon as they appear. So we had in Serena 6 about a little more than 300 patients that have been randomized. So patients with ESR1 mutation being detected. These patients are doing perfectly well. CT scan is telling us that they have no disease progression. Yet these patients were at risk of early progression because of this ESR1 mutation being detected in their blood. So patients were randomized in Serena 6 between staying on the same treatment, so which means we are dismissing the molecular information we're getting from the blood versus the switch AI being replaced by camizestrant and the CDK4/6 partner being unchanged. The results are, I think, very interesting. So not only they confirm that the switch is useful in terms of progression-free survival. So patients had a much longer progression-free survival when they were switched to camizestrant with an hazard ratio of 0.44, which is rarely seen in this context. But also we could see clearly that the curves were diverging early, so which means like all patients have some time to benefit, and it's not a strategy that applies only to a subgroup of patients. So that's very interesting. And also we have very long responder with this kind of strategy. So overall, what we got in terms of safety, very few adverse events with camizestrant, most of the adverse events being related to the CDK4/6 partner. So again, here, no issue with bradycardia. And interestingly, so this efficacy, this safety data are also complemented by something that is very new and very unique, which are the quality of life data. These data were not documented before Serena 6, so not part of PADA-1, which was the first trial to investigate the switch. And we had very interesting results in terms of quality of life, but these were presented by you, Erika, so I let you present them to the audience.
Yeah, so the quality of life data from Serena 6 is so interesting and really, I think, illuminates a lot about the patient experience for those who are in the trial. In addition to the really striking benefit in terms of progression free survival, there was also a substantial delay in time to deterioration in global health status, about a year and a half prolongation until patients receiving camizestrant had a deterioration in how they felt overall. We were able to dig into it a little bit more to understand what's driving that. And in terms of kind of the different types of quality of life features that were being looked at, there were symptoms related to how patients were feeling, and there was also how patients were functioning. And what was demonstrated is that switching to camizestrant substantially decreased the delay to deterioration in the patient's symptoms. And I'd say most notably, this included pain, fatigue, and shortness of breath, as well as patient functioning, including role functioning, like how they're able to function, their physical functioning, like able to do things around the house. In particular, I think when we first saw some of this data, there were some questions about whether patients were feeling better because maybe they tolerated camizestrant better. But seeing that there was this significant delay in time to deterioration in symptoms like pain, fatigue, and in particular, shortness of breath, these are the symptoms of subclinical cancer progression. And to me, it suggests that making that early switch to camizestrant when we find the emergence of the ESR1 mutation, but there's no radiologic clinical progression, is really helping preserve how patients are feeling. It's preventing them from experiencing the symptoms of cancer progression. I think Serena 6 is super exciting, although, of course, using the strategy is not yet an approved regimen or an approved type of way to be treating patients. But I think we're all excited to perhaps bring this into practice. I'm wondering, based on your experience in Serena 6 and in PADA 1, who would you think about monitoring if we have the ability to do this serial ctDNA monitoring? How often would we test? Who would we test? How many times would we test? What's the sweet spot for testing?
Yes, that's a very important question when it comes to clinical adoption. So, in Padawan we tested every 2 months, and in Sena 6 it was more every 3 months. And I think that uh, these trials were not designed to assess what is the best and optimal interval for testing. It's more about fitting to the patient visit to the hospital. And Padawan was conducted at a time when palbociclib was a kind of new drug, and we wanted to see our patient every 2 months, at least at the beginning of the treatment. And then we learned that we could relax a bit. And now I'm perfectly fine. Patients that are doing well on CDK4/6, palbociclib, or whatever, could be Abema, could be Ribo. I would see them like every 4 months, or even some of them every 6 months with a very long responders. So what I would keep from a clinical perspective is, a patient should not come to the hospital too often. So my recommendation would be to keep and to stay with the visit at the hospital, especially in Europe when most of ctDNA testing will be done at the hospital. So we don't want the patient to travel to the hospital just for ctDNA blood draw. So I would say that testing 4 times a year, as in the trial, is very perfect. But 3 times a year, or maybe for some patients 2 times a year, is better than nothing. So we know that we would still be able to intercept the ESR1 mutation. So and if there is an ESR1 mutation, it's very needed to switch the treatment. So overall, testing a bit is better than nothing when we see all the benefits that the patient derive from the strategy. When it comes to which patient to monitor, at the moment with PADA1, we have been able to report, let's say, clinical characteristics that are associated with a bit more or a bit less ESR1 being detected. But at the moment, it's not something that can really guide clinical practice, because these are, let's say, relative changes that are kind of tiny. So at the moment, I would test all my patients, but probably in a more relaxed setting. And then, of course, when you test, you need to explain. And, that's something that's, you need to explain to the patient why they are doing this blood test. And Erika, you also participated, I think, to Serena 6. So you certainly had to explain your patient what you were seeking in their blood.
Yeah, so thanks for reviewing your strategy. I think the idea of testing a patient 3 or 4 times a year sounds very reasonable and something definitely we can do in practice. I would just reflect on in treating my patients on Serena 6 and explaining how we are looking for an emergence of a resistance mutation and we're doing it in real time. I think there have been some concerns in our breast cancer community that made patients feel anxious. Actually, I had the opposite. My patients were so excited to learn in real time what's going on with their cancer and have the ability to act on it. So I actually found that patients were really excited to partner in this process of serial ctDNA and to really gain knowledge through the most up-to-date technology. So the concept of sort of scanxiety, I didn't actually find that applied at all to Serena 6. Well, we're just reaching time, so we're going to be winding up. But I just want to also note that we are awaiting results from first line trials of oral SERDs. We're waiting for the Persevera trial, moving giredestrant into the first line setting, and the Serena 4 trial, moving camizestrant into the first-line setting. Both of these trials randomized patients to receive oral SERD with CDK4/6 inhibitor versus endocrine therapy with CDK4/6 inhibitor. So, Francois Clement, thank you so much for such a great discussion. It's such a pleasure to speak with you today. And thank you to our audience so much for participating. Please continue on to answer the questions that follow and complete our evaluation. Thank you.